I'm Dr. Mark Gold, and this is the Gold Standard. It's my great pleasure today to have Dr. Daniel Amen here with us at the Gold Standard. I haven't seen him in a long time, and we have lots of ground to catch up. But hi, Dan, and thanks for doing this.
Mark, what a joy. When I got the email to do this, I just immediately said yes.
Well, you are a one of a kind. So I asked Google, I said, who's the most famous psychiatrist in the United States? I don't know if you ever asked that question. I asked the question, like, how many citations does Nora Volkov have versus me? But I've never really asked that. And it said you. And it said, in addition, that you were an unusual American psychiatrist in that you're board certified, you've started your own clinics, you've been among the bestsellers of the best-selling authors, maybe even of all times in psychiatry. They compared you to Dr. Spock as an author. And then it said that a variety of other things. But let me leave it at that. Like, was that your ambition when you finished Walter Reed?
No, my ambition was to be a really good psychiatrist and a writer. I wanted to write about what I was learning about because it was so interesting. And I find that it helps me personally be better, have a healthier brain, manage my mind, and it helps a lot of other people. I just had no idea. And then when I started looking at the brain in 1991, it literally changed everything in my life. It's not mental health, it's brain health. Get someone's brain healthy and their mind is better. And I think I'm most proud about that concept. And it directly applies to addiction because the real reason not to use drugs is they damage your brain. And if they damage your brain, they damage your life. And, kids, they tend to oppose just to individuate. But I want them to oppose the marijuana industry or the alcohol industry, rather than their mom or dad.
I mean, that's a really interesting road to go down, and I'm happy to do that. For psychiatrists as a group, they've not applied any rigorous evidence to their decision to not oppose cannabis or kids smoking cannabis or using drugs. I did this review that was just in JAMA and did one before that as a American Psychiatric Association Council report looking at what's the controlled study evidence for medicinal, quote unquote, cannabis, and there was none. When I did look up your work and ask about that, you even have public appearances where you and I would be 100% aligned that drugs of abuse are dangerous until proven safe and effective, and until you needed some special reason that we ought to be giving you or you should be taking medications.
Yeah, it's crazy. And I'm worried about the psilocybin thing. And it's like I've seen this party before 5 times. That when I trained at Walter Reed, I think Xanax came onto the market and it was mommy's little helper. And, it was better than some of the other benzos. Absolutely a lie. When I started imaging, I stopped prescribing benzos because they make your brain look older than you are. And then it was alcohol as a health food. No, that's a lie. It's associated with 8 different cancers. And then in the 90s, it was pain is the 5th vital sign. And you were bad as a doctor if you didn't relieve suffering with opiates. Well, that turned out to be really bad. And then marijuana is innocuous, complete lie. and now everybody's excited. I've been doing work with the White House, and everybody's so excited about psilocybin. And I'm like, well, emergency room visits for psilocybin psychosis are going up. Shouldn't we be careful? And we're not. So teenagers now are having mushroom parties. Um, when you love and care for your brain, you never want to hurt it. But without imaging, so our whole field, I've been called crazy because I think you should actually look at the brain before you go about changing it. And I'm not crazy. That's the next iteration of really good psychiatry. It's, yes, you have to talk to people, but you have to add imaging. And then you have to help people fall in love with their brain and get it healthy.
I didn't want to get in the weeds on this, but I've worked in areas of brain computer interface and high density EEG, and the technology is really, really difficult. So, yes, I agree that ideally we should be able to look in the brain. I agree that we don't. You and I probably even agree that some of our psychiatric diagnoses are really don't make any sense. I mean, for me, it doesn't make any sense to have alcohol use disorder, cannabis use disorder, opioid use disorder, cocaine use disorder, when there's probably only one addiction. And now in our field, they're saying maybe we shouldn't even do tests for drugs and only I know the ASAM sent out draft criteria for drug testing, and part of it was we don't want to stigmatize people. And I'm saying, well, most people use 3 or 4 different drugs, not only one drug. Most people only tell you about the drug that's the least offensive. But so I think there's the test. I don't have any doubt that there's a role for testing. I only had doubt of which kinds of tests made the most sense for which people. So you and I will again converge on this. Like when we take a history of drug use, we don't ask people, now you do, I'm sure, like if they've ever overdosed or if they've ever overdosed and needed rescue with naloxone. All of those would be indicators that they have brain damage. And you probably have data that shows damage related to overdoses or head injury, or all of which are very common in people with substance use disorders.
There's so much there. I think today quantitative EEG is helpful. I think SPACT, I do both. I have 11 clinics now around the country. And we started with QEEG. Did a week with Frank Duffy at Harvard in 1989 of all times. And I like QEEG. And in 1991, I started doing SPACT. And we have a database of almost 300,000 scans. So almost anything in psychiatry you can imagine, we've imaged. And the lessons are just endless. Like the real reason not to use drugs is they damage your brain, or depression is clearly not one thing. Depression is like chest pain. Nobody gets a diagnosis of chest pain because it doesn't tell you what's causing it. It doesn't tell you what to do for it. But I think both SPACT and quantitative EEG could be utilized now. And no other branch of medicine relies on one study. Right? Cardiologist is looking at the electrical activity in your heart, how your heart moves, the blood flow to your heart. And that is why stigma is still a serious problem, because we keep calling people mental. And, call somebody mental and you shame them. Call them a brain and you elevate them. I think if we really want to get after the substance abuse issue, we have to get people to fall in love with their brains. So I was at the White House and I got to sit next to Lisa Trout. So Lisa and her husband, Kenny, own Justify. So Justify is the last Triple Crown winner, sold for $75 million. And I do a lot of drug education. And I often say, if you had $1 million racehorse, would you ever feed him junk food? And like, of course not. And so I asked her that question. I said, well, would you ever feed Justified junk food? And she laughed and she said, no. I said, would you ever get him drunk? She said, no. Would you ever get him stoned? No. I said, why? He would never live up to his potential. But we don't teach young people that their success in life is directly correlated to how healthy their brain is. And when your brain is healthy, you think better, you feel better, you act better. But because they just never get that education, we have a high school course called Brain Thrive by 25, and it's in all 50 states, and it decreases drug, alcohol, and tobacco use because we teach kids to love and care for their brain. But isn't that a message that psychiatry should embrace? We are a brain health specialty, right, but in the divorce with neurology, we lost the brain. And I think that was a bad divorce. It was a bad decision on our part.
Well, that resonates with me. We've tried to think about in drug prevention delay, and that really missed the point. So the first idea was delay use, like push it to 21, and we had the kind of pseudoscience that said that the brain's fully developed at 21. Okay, so now we say, no, it isn't close, and maybe it's 35, or like the fact is that the most important connections form latest.
Well, we actually have evidence that in your 60s, your frontal lobes continue to develop unless you're bad to them. And one of the craziest findings is as your weight goes up, the size and function of your brain goes down. And now with 75% of Americans overweight and 42% obese, it's like, oh, we have to talk about this without shaming anybody, because most people don't know. But when I figured out that connection, a paper from the University of Pittsburgh in 2009, I lost 20 pounds because I don't want to have a smaller brain.
Well, I remember a paper by Nora's group with Jean-Jacques Wang, and they had the somatosensory homunculus, and they had the relative size of various representation in that homunculus, depending on your body mass. So in her obese sample, there was almost all mouth and things associated with taste. And I remember asking her, I said, like, what happened to like genitals? And so she said, like, basically, most of the sensations around eating are reinforced as you become more and more overweight, and the rest of the sensation map falls off.
That is so interesting.
Yeah. Well, so the healthy eating, of course, I remember Bart Hubble very well. We worked together in the 80s. He helped me a great deal understand that food was a drug. He helped me kind of bridge the gap with the Yale Science Group and why alcohol's a drug, because it's fermented sugar and alcohol. We used to have these Yale monkeys in St. Kitts that ran wild. I know I showed you that movie in California that one time, and they would seek out fermented sugar cane, and you could reduce their seeking by giving them naltrexone. All of that showed that alcohol was the closest to food, and therefore we made the point in the 80s, and Nicole kind of carried that on, that food and drugs are quite similar in their effects on the brain. You've been a messenger for that, like on low ultra processed food consumption, managing your blood sugar. We Nicole's group at Princeton showed animals would self-administer sugar like a drug, but you really got the word out to people, and we were all thankful for that.
Yeah, thank you. If you think of it as mental health, diagnoses are made with symptom clusters with no biological data. And now 25% of adults are on psychiatric drugs. If you think of it as brain health, you have to eat better. Alcohol is not a health food. Marijuana is not innocuous. Exercise is critical. You need to go to bed early. It's when you think of this actually as an organ to love and care for, so many psychiatric problems get better.
Well, you're a great communicator, and I'll go through some of the things I remember about your writing. Food hijacks the brain. We used to say drugs hijack the brain, but food's a better example. You've all made the point that, like a brain health and protecting your brain, you even broke that down to like protect the dopamine system. You can't protect the dopamine system and use psychostimulants or drugs of abuse, because at certain doses they're neurotoxic. I don't know. I think that those are all big contributions, and that plus your prevention efforts are they don't tend to get noticed.
Well, I've been working with HHS recently to so we're working on a project called the Decade of Brain Health that hopefully sometime this year we'll announce that, to just begin to change the conversation away from mental illness toward brain health. And I'm very excited about that. I got to meet with Dr. Marquetta Wills, who's the CEO of the APA. And we were at a meeting at HHS together. I said, it sort of felt like I've been at war with you guys for a long time. And she goes, well, let's chat. And so I told her what we actually really do: detailed clinical histories, imaging, cognitive testing, and then we help people get better physically, emotionally, relationally, and spiritually. And she said something to me I'll never forget. In fact, I'm going to put it on my tombstone. She said, "You were just early." which is not that fun place to be. But I love this work so much that when you make someone's life better, it impacts generations of people. I figured that early on. That's why I became a psychiatrist. Someone I love tried to kill herself. And I realized if the doctor who saw her, Stan Wallace, I remember him, loved him, if he helped her, which he did, it wouldn't just help her. It'll help her children. It'll help her grandchildren. And we can just do so much better.
Yeah, I mean, when I think about the eating work, that's been great. Drug prevention work, alcohol prevention, very, very important. And you mentioned exercise. You probably know Peter Thanos and I have been working on high intensity exercise as a kind of neuro rehab, and showing maybe TMS can get connections going again. Maybe other ways can cause dopamine systems to return to pre-morbid function. but exercise is about the best we have. And you've been a preacher for exercise.
It's just so important. I have an acronym you might like called Bright Minds. You want to keep your brain healthy or rescue it, you have to prevent or treat the 11 major risk factors. And SPECT is a blood flow study. It looks at regional cerebral blood flow, but also mitochondrial activity, 49% of the tracers taken up in the mitochondria. So Bright Minds, the B is blood flow. So that's number one. You want to keep your brain healthy. You have to prevent the things that decrease blood flow. So being sedentary, being overweight, alcohol, marijuana, and then increase blood flow, high intensity exercise, absolutely perfect. But then things like ginkgo and beets, managing your blood pressure, so magnesium can be really helpful. And I used to say whatever's good for your heart is good for your brain, because your brain is 2% of your body's weight, but uses 20% of the blood flow. And then I wrote a book called Sex on the Brain. And I'm like, oh, whatever's good for your heart is good for your brain, is good for your genitals. Whatever's bad for your heart is bad for your brain, is bad for your genitals. And 40% of 40-year-olds have erectile dysfunction. And I think that is directly related to our unhealthy lifestyle.
It's funny, you talk about cardiology a lot, and that's where SPEC is used the most, and where the American College of Cardiology endorsed it, even though some people might argue that why didn't they use PET or others? And what do you think the resistance is? Is it the radiation exposure? Is it that as a discipline, psychiatry is always late for diagnostic test reimbursement or interventional treatment?
So I think we're almost at a breakthrough point, because our outcomes are not better than they were in the 1950s, and we sort of should be ashamed of that. And I didn't say that; Tom Insel said that. If I'm right, and I am, I think, psychiatrists should look at the organ they're treating. What that means is 40,000 psychiatrists are wrong. And Thomas Kuhn wrote this great book in 1962, The Structure of Scientific Revolution. And he talked about revolutions go through 6 stages. 1, normal science, you're just going along, doing what you do. And then 2 is somebody notices a problem. And in 1991, I noticed a problem that someone would come in with depression. I would put them on Prozac, and now they'd want to kill themselves or somebody else. And I'm like, no, I'm missing something. And a paper from Harvard came out in 1991 that said SSRIs, particularly Prozac, can hurt a small percentage of the population. And then I went to the lecture on brain SPECT, and and this has been proven since then, if you have hyperactive frontal lobes, especially the subgenual cingulate gyrus, you respond to an SSRI. If you have sleepy frontal lobes, they make you worse. And so I noticed a problem. Well, stage 3 is the status quo notices a problem, but to protect the money, they make small incremental changes. Step 4, somebody comes up with a new mousetrap. DSM, yes, we have to know how to diagnose people, but then add imaging and natural ways to heal the brain. And it's a more rational approach, I think. Step 5 is the rejection. It's the most common, consistent stage. And then stage 6 is the acceptance, because younger practitioners go, we need a better way. And I think we're actually between 5 which is why I'm excited to have a meeting with the DSM committee in August to go, we need another axis. Yes, here's the diagnosis based on what you see, but the next axis should not be a personality disorder axis. It should be, and here's the physiology that underlies what you're seeing clinically. And I think when we add that new axis on physiology, whether it's quantitative EEG or SPECT or PET or ASL or fMRI, the whole world is going to change and our outcomes are going to be better because we're going to turn into a real brain health specialty, which I'm just endlessly excited about it. And, why did SPECT get a bad rap? Because of the researchers that were getting millions of dollars, not for SPECT, but for PET and MRI. It's the only reason SPECT, there's 13,000 SPECT cameras in the United States today. There's a radiopharmaceutical that gives you beautiful images. The resolution's not as good as PET or MRI, but it's good enough. It's 6 millimeters. And now we have the world's largest database that I freely share that we can just start comparing patterns to. And the scans, and the APA made a huge mistake. They said you cannot use imaging unless you can get sensitivity and specificity above 80 against the DSM. So the DSM, which is a circular document, it makes symptoms to create diagnoses with no biology, is now expecting biology to reinforce it, which of course it'll never do. But we can separate with those kinds of numbers, PTSD from TBI, major depression from Alzheimer's disease. And it's just time for us to be more rational and add a biological component, whatever that might be.
Well, it's interesting. You bring this up at the same time that ASAM's talking about taking away drug testing. So there are these countercurrents, and they've positioned that related to stigma and shame. And I've always said, well, if a person has cocaine intoxication, they have cocaine in their body. And if they have a cocaine use disorder that's current, they have cocaine in their body. And the same would apply to other drugs. And if you just looked at cocaine, didn't measure cannabis, alcohol, nicotine, whatever else, you would be 100% relying on the person to diagnose themselves.
They lie to us all the time, right? I mean, any doctor, 80% of your patients are lying to you. And if you don't look or you don't test, you don't know. And why would you fly blind unless you were sort of an idiot? That's what gets me into trouble because I'm not politically correct. Why would you fly blind and believe people who are using substances who feel shame, which is why they're lying?
Well, we think about it with impaired health professionals. We use testing and it helps us. Like in the state of Florida, we have a testing system for people where they call an 800 number. They're randomized to test or no test every day. So every day is kind of like a CBT treatment. They're randomized. And then if they're positive, they're evaluated again. They probably go to a higher level of care. But DuPont, McClellan, the group showed that system had an over 80% recovery rate. Well, if you're going to eliminate testing, you can't, I agree, you can't expect a person to tell you. And then I'll make it worse. The new research out there says most people don't even know what they're taking. You took your example of psilocybin. There's a study of some state of Washington or Oregon's psilocybin. It's not even psilocybin. Or the MDMA, there's a drug study in New York and showing that the MDMA is an MDMA. So even if a person is telling the truth, what they're saying may not be the truth.
And if you don't look, you don't know.
Yeah. So I point
It's
this out to you only because it's a countercurrent. There is a movement. I'm part of it. I've said I don't really care about the DSM diagnosis. Can somebody give me a diagnosis of lithium responder? Nathan Klein.
and that's the more important. That's the more important question.
Yeah.
And SPECT has a dozen outcome studies on if you have low frontal lobe function, you are much more likely to relapse. And that makes sense.
Makes sense.
But if you don't look, how do you know if the 4 concussions you had playing football in high school are not impairing your ability to inhibit things that are not good for you? And so I did the big NFL study. You know, when I look back on my career, it's some of the most fun things I did. That's on the top of the list. I scanned and treated 400 NFL players at a time when the NFL was sort of having trouble with the truth on traumatic brain injury in football. And I published the first study in the Journal of Neuropsychiatry and Clinical Neurosciences on 100 NFL players, high levels of damage. But 80% of my players got better when we put them on a rehabilitation program. So the whole messaging around CTE, chronic traumatic encephalopathy, is a lie. It's because the message is it's chronic, progressive, and untreatable. That's not true. 80% of my players get better, but you have to put them on a brain healthy rehabilitation plan. And the earlier you do it, the better. But we also did a study at Sierra Tucson looking at 500 consecutive new admissions. 44% reported a significant history of head trauma. And if you don't look, how do you know if that head trauma was healed, or does it still leave a signature in the brain that impairs them from being well?
That to me seems to be in an area that is reimbursable, is neurological. Like when I thought about the challenge that you had, and I said, well, gee, in overdoses with rescue and anoxic brain damage, you won't know who has it and who doesn't have it unless you do scanning. And then we have people with substance use disorders. Everyone knows they have more fights. They fall down the steps. They have head injury. There's good data on that, but you don't know who has residual deficits unless you look in the brain. Both of those areas don't seem controversial, but somehow you got controversy there too.
Yeah, there shouldn't be, because, and I can tell, so for the DSM document, we've mined our database to go, okay, here are the top people in our database, at least have 100 people. Can we tell them from each other? And toxic encephalopathy is the easiest thing to tell against almost every psychiatric diagnosis. Traumatic brain injury,
Right.
Easy. Alzheimer's, easy. But how would you know if you never looked? And so the idea, CMS has this new grant program called Maha Elevate, which is very interesting. And I've been friends with Dr. Oz for 20 years, and he told me about it, and we applied. Maha Elevate is to take a functional lifestyle medicine program and apply it to a Medicare group. So we did it for depression, and see if you have a better mousetrap. Well, we did image-guided depression treatment. Will that separate from just a good functional lifestyle medicine program. So it's these kinds of studies that I think will begin to make imaging more reimbursable. For a long time, I was just mad at the insurance companies. And so I'm like, look, if you want to see me, pay me. I just can't fight with them anymore.
So are you interested in TMS too?
So I'm very interested in TMS. Do you know Jonathan Downer?
Yes.
So he might be an interesting guest, but he has this 1 day TMS
Yeah, yeah.
protocol that I'm really interested in using D-cycloserine
Yeah.
ahead of time to increase neuroplasticity. But I thought one of the reasons TMS is not as effective as it could be is they assume, sort of like the STAR-D trial,
Right.
that we should start with one protocol, which is, and anybody that's imaged more than 100 depressed patients, and we've imaged probably 40,000, is you go, there's some low activity depression, there's some high activity depression, there's some head trauma depression, there's toxin depression. Give them all the same TMS protocol and you are not going to do great.
Well, I had the second TMS machine, and at one time I went over to Wales and was working with the inventors of TMS, who happened to be there, and they became the Magstem corporation over there, and basically I learned the hard way that even if TMS was safe and effective, they made you try it only in people who failed SSRIs. And then it was twice as effective as adding another antidepressant. But the gold standard interviews, I interviewed the WashU guys, and they said if you turn the algorithm upside down and had everybody start with TMS, there might be very little left at the bottom to treat with medications. And also in China, I was very surprised when I went to China that TMS was a first treatment rather than a last treatment. And their thinking was depression was a disease of the brain. Why treat every cell in the body?
What a concept. And when it came out, I'm like, well, why wouldn't you do that first? Why wouldn't you sort of reset the circuits first rather than put someone on a medicine that's going to decrease their libido and make it harder for them to have an orgasm? It's like, how does that make any sense? But because we don't look at the brain, we sort of have the idea, oh, depression is a serotonin deficiency, so let's increase serotonin, everybody will be better. Except when Prozac came out in 1988, depression has dramatically increased since then. So obviously we're not fixing anything.
Yeah, I couldn't agree more. I looked at it more like TMS required you to know about the brain. You have to know where to put the magnetic coils, right? You have to know positioning. I thought it was the initial resistance was about like, who's going to do it? Who's going to put this big chair in an office? Like it was the same thing to urine testing, or even the same thing to injectable naltrexone. When Alkermes had the injectable, they asked psychiatrists, and many said they don't have the ability to give an injection in the office. And then when urine testing came out for drugs, many psychiatrists said they couldn't take a urine test because of the doctor-patient relationship and the necessity to supervise. And for TMS, how many doctors have spare room for a machine, and how many are comfortable with the brain to place it?
Yeah, I think neuroscience needs to be a much larger part of psychiatric training. So when I told my dad in 1979 I wanted to be a psychiatrist, he asked me why I didn't want to be a real doctor, why I wanted to be a nut doctor and hang out with nuts all day long. And that hurt my feelings. And he wouldn't have gotten Father of the Year award. But it sort of makes sense now a little bit. It's like, why are we the only medical specialists that virtually never look at the organ we treat? And I had a conversation with Nora Volkow, and I'm like, and she goes, the brain has language. And I just looked at her like that was the dumbest thing anybody could have said, because the brain doesn't go, oh, I'm being poisoned by mercury, or oh, I live in a mold filled environment, or oh, my anxiety is because I got bit by a tick in Lyme, Connecticut. It's like, no, if you don't look, you don't know.
Well, that's so interesting. Tell me, like, why should we feel good about the future of psychiatry? And I mean, you're still like very engaged. I'm very engaged, and we're active in the field. Why are we so optimistic with all this going on?
Well, it's the one area of medicine that has the most growth to do, that we're still a bit in the dark ages and we can do better. And if we can do better, it's like, all right, let's convince people we can do better and do better. I treated Paula White. It's public knowledge. She did my podcast. She's the director of the White House Faith Office. And she like, I want to get your work everywhere. And so I think you do the work and then, hope for opportunities to share it. And because of her, I got to meet with Bobby Kennedy, and, HHS has a bigger vision, and hopefully what I really want is I want the DSM to have that second axis of physiology, biomarkers, because it'll just change everything.
Well, I want to thank you for spending your time with us and sharing your thoughts and vision for the future. You've done so much, and it's a lot nicer to see you here than on a PBS special or reading your book. I mean, you're a truly engaged, charismatic, forward thinker who's really, you share so many common beliefs with so many psychiatrists, and I doubt they realize that, and hopefully they will at the end of this podcast. So thank you, Dr. Dan Amen, for joining us at the Gold Standard.
Thank you, Mark. What a joy.